We're here in San Diego this afternoon at the 2016 American Society of Hematology, and joining me this afternoon is Dr. Marco Davila. Doctor, good to see you.
Nice to see you.
So you're with the H. Lee Moffitt Cancer Center and Research Institute, and your area of specialization is immunotherapy. And it's something that we've been hearing a lot about at this conference, immunotherapy, combination therapy. We all know what chemotherapy is, right? That's been around for a while. Can you share with our viewers what is immunotherapy?
Sure. Immunotherapy is one of those 100-year-long overnight successes. So while people have been hearing a lot in the press about it in the last few years, there's been a lot of scientific research and progress in this field over the last several decades. So if someone thinks about what was the first kind of concept of immunotherapy, it was probably based in New York with a surgeon at Sloan Kettering Cancer Center, where you noticed that patients that had certain types of infections actually had regression of their cancer. So that kind of spurred this thought in Dr. Coley, the surgeon, that there's that potential that the immune system may actually be able to combat cancer. So the immune system, which normally people think is important for combating bacteria, viruses, and fungi, may actually have a role in combating cancer. So for several decades, people tried to build up evidence that that was actually an important part of the immune system. And we've had bits and pieces of indirect evidence, such as in bone marrow transplantations, patients that are immune suppressed. Those conditions can make patients either prone to having eradication of their disease or actually being prone to developing cancers. So there's a lot of indirect evidence, but really the last, I'd say, 5 to 10 years, there's been just a tremendous progress in terms of really defining that one of the pivotal roles of the immune system is to recognize cancer and to eradicate cancer. And the therapeutic advances we've been experiencing these last several years is because academic investigators and industry drug companies have been able to devise therapies to intervene in that and allow the T cells to be able to, allow the immune system to be able to kill cancer again.
So the new therapies that the pharmaceutical companies are working to bring to market are essentially assisting the immune system in going after the bad cancerous cells.
Absolutely. There's 3 main classes of immunotherapies. One is called adoptive T cell therapy. The second is called bispecific T cell engineering, and the third is called checkpoint inhibitors. Now, all those drugs, while they work differently, or all those therapies, while they work differently, they all involve trying to target the T cell against the cancer.
Okay, so tell me a little bit on how they work the same and how they work differently.
Sure. So probably the easiest way to describe, first of all, the checkpoint inhibitors is that both cancer and the immune system have a very close interrelation to each other. So people have discovered through studying the immunology of cells associated with things like tumor metastases have actually determined that there's certain functional characteristics associated with tumor-reactive T cells. So immunologists have discovered that as part of just the negative system to be able to prevent T cells from getting too activated, causing problems like autoimmunity, that there's a negative regulatory system to suppress T cells. Now, cancer has actually co-opted that system. So when tumor-reactive T cells come into a cancer deposit, the tumor cells express these negative receptor ligands, and they cause the T cells to become suppressed. So checkpoint inhibitors basically work by blocking that interaction. So the negative regulatory signals that the tumor provides is not recognized by the T cell anymore, and the T cell is able to kill the tumor. So that's checkpoint inhibitors. Okay. The bispecific T cell engagers in adoptive T cell engineering basically work by trying to target the T cell directly to the tumor. And this occurs through the protein, basically by the bispecific T cell engagers has one part of the protein that recognizes the tumor cell and the other that recognizes the T cell. And it brings them in close proximity together. And when that happens, the T cell gets activated and kills the tumor cell. A similar concept with the adoptive T cell therapy, what we do is we put in a gene that causes the T cell to recognize the tumor cell. And that brings the T cell in close proximity to the tumor cell, and it causes the tumor cell to be killed by the T cell. So really we've seen some phenomenal responses in metastatic or from chemotherapy refractory metastatic disease, meaning that the standard therapies that you mentioned before, chemotherapy, no longer work for these patients. Lung cancer, melanoma, acute leukemia. We've all seen patients getting into not just remissions, but durable remissions with these therapies. So from the medical oncologist perspective, this is really unheard of.